Good afternoon. Good afternoon. Can you use the mic on? I'm sorry to have to interrupt your conversation, but for the sake of time, there we go. I'll get my playground voice out here. Sorry to have to interrupt your lunch and your conversation, but for sake of time, we wanted to begin the program, and it's really my distinct honor to be able to open the program. I'm Jack Logue, and I'm the Chief Operating Officer at St. Vincent's Medical Center. And I want to be able to say to all of you that you are most welcome, and on behalf of Heart and Lung Institute at St. Vincent's, and for the whole Baptist St. Vincent's Health System, to welcome to you to this, our celebration of the 10-year anniversary for the Heart and Lung Institute. Probably most proudly, I'm able to be able to announce the beginning of our newest service, the Center for Heart Attack Prevention, and you'll be hearing about the Center for Heart Attack Prevention more. But over the past 10 years, the Heart and Lung Institute has provided many programs and services. It has advanced diagnosis and treatment of both heart and lung disease through research, physician education, community health promotion, advanced technology, and certainly patient care. Since 1985, the Heart and Lung Institute has been recognized for initiating new educational programs with a strong emphasis on education, as well as patient care services. During this program, you will receive information more specifically about the Center for Heart Attack Prevention and how this Heart Healthy program will help you and your employees and our community. So I want to thank you again for joining us. I think you'll find this a stimulating program. I'm sure that you will enjoy it. And we'll begin with an invocation, which Joe Mitrick, our Vice President for Patient Care Services, will offer. Joe?
Let us pray. Lord, during this holiday season, we thank you for all the blessings that you've bestowed upon us, our lives, our loved ones, all that we have and all that we are. We thank you for this gathering today and for the opportunity to hear Dr. Roberts speak to us. We ask that you guide us in our efforts to meet the healthcare needs of the Jacksonville community. We ask for these things in your name. Amen.
Well, good afternoon. It's certainly a pleasure to have you all here today. As I told many of my friends, don't take this invitation you initially received as very personal, but we do want to increase the heart health awareness here in Jacksonville. I want to review with you all how this all came about and kind of review a little bit about the cardiology history of St. Vincent. In 1972, Dr. Angel de la Torre, who was back then the chairman of the cardiology division at University Hospital in Gainesville, was recruited by the Sister of Charity to come to Jacksonville and open the cath lab at St. Vincent's, and since then has done an unbelievable job. I think we've done looking at some numbers, over 35,000 heart cath and many thousands interventions. But back then, Dr. de la Torre named this cath lab, he named it a diagnostic cardiovascular unit. And the point was that in the 70s, we could do a lot of diagnosis, that is, know what the patient had, but we couldn't do much about them. And that was pretty much how medicine had been for many, many centuries. You could diagnose, but you couldn't do much. Throughout the years, as you all know, balloon angioplasty has come around, and actually a new field of cardiology has evolved called interventional cardiology. Can I have the first slide, please? Which essentially means that we can intervene in the coronary arteries, or the arteries or the vessels that give blood supply to the heart. And here's an example of a healthy artery shown in the upper portion with Dr. Roberts here further. It's a healthy artery. These are the layers of the artery, and blood flow goes through here. And here's an artery with atherosclerosis, or fatty tissue. And you can see how this fatty tissue forms everywhere. And actually, this is not a very localized problem. It happens all over the arteries. And therefore, if blood flow is going from here to there, it obstructs. Can I have the next? When we do a balloon angioplasty, what do? We temporarily take care of things. Here's an example of a balloon in that area. As you can see, we inflate the balloon. The balloon does not cover the entire surface. There's usually blockage all over the place. And we kind of patch things up there for a while and really do not have any major effect. Recently, we've placed stents, which is another expansion of this. It's a little type of mesh material that helps us to prevent this artery from collapsing. But again, look right here, in many other places, this atherosclerosis or fatty tissue occurs throughout the entire artery. Other modalities of treatment include open heart surgery, and I just want to show this slide to you all. Actually, this is from a study that was done recently comparing St. Vincent's Medical Center with 5 other hospitals which were chosen from the U.S. News and World Report of the top 5 cardiac hospitals, comparing our surgical mortality with other hospitals. You can see is Mayo Clinic in Rochester, Duke University in Durham. Here we're right here around the middle. Cleveland Clinic, Mass General Hospital, this is national average, Stanford University, and we can do a very good job with surgery. But that really is, we can intervene, we can do things, but we're not getting to a problem of it. And that's how this Center for Heart Attack Prevention started. And it is with our hope that we can prevent more. We probably might be out of business, but if we can do this, we truly accomplish our goal. And what we hope in the future is that somebody would never get to this stage, but if they do get to this stage in which fatty tissue happens, after you go to the Center for Heart Attack Prevention, your artery will look like this instead like that, like this, and you would not have to require any type of intervention. With that said, so I want to pass now the microphone to Dr. Salcido, one of my partners, and give him his word.
Thank you, Carlos, and good afternoon to all of you. As we celebrate the 10th anniversary of the Heart and Lung Institute, it's really appropriate and a pleasure to also open a new program, as has been mentioned before, and that's the Center for Heart Attack Prevention, or CHAP, as we call it. We were just talking to Dr. Roberts a moment ago, and he said, listen, this CHAP thing sounds like it's for men only, so we have to put a CHAP and CHAPette. But for now, we're going to call it CHAP. And CHAP, or the Center for Heart Attack Prevention, really has been developed, or we're organizing it, to try to help the primary care physician help their patients. The idea then is to promote heart health. And we are really doing this with many things in mind. We're going to have within the Center for Heart Attack Prevention a lipid clinic. And we are very grateful to Merck for having us help, actually not only in the program of today, but on helping us launching this part of the lipid clinic, which will be part, as I said, of the Center for Heart Attack Prevention. We want to reemphasize the aspects of cardiac rehabilitation. We want to reemphasize the aspects of education, nutrition, exercise, weight control, and we want to organize this in a way that the members of CHAP will be like club members of a Center for Heart Attack Prevention. We will keep track then of their profiles, of the risk profiles, and modify them as best as we can. So we're very pleased and very happy to announce the opening of CHAP today. And it's really a pleasure for me to introduce our keynote speaker, Dr. William Roberts, who's going to address this audience today. Dr. Roberts is the director of the Baylor Cardiovascular Institute in Dallas. Dr. Roberts really is an internationally renowned speaker. He's originally from Georgia. Actually, he's the father and son of a physician, both in the cardiovascular field, and has really tremendous experience and has published innumerable papers and articles, over 1,000 articles related to cardiovascular disease. He has had a long love affair with cholesterol and how to really modify the ravages that cholesterol produces in people. And we're really very pleased to have him address this audience today. With you is Dr. William C. Roberts.
Well, thank you very much, Ernesto. I appreciate those kind words, and I appreciate the opportunity of being here today. I had not been to St. Vincent's Hospital before. I was given a lovely tour this morning, and I must say that if I got sick, I would like to be in that hospital and look out the window and see this beautiful river. It almost pays to be sick here in Jacksonville. While you were speaking, it reminded me of the dentist. As I understand it, the dentists were really behind fluoridation of water, or they at least supported those efforts enormously. And yet the dental caries, which is our #1 disease, has really been knocked for a loop by fluoridation. The number of cavities in young people now has dropped enormously. So for cardiologists and cardiovascular surgeons to get behind the prevention of atherosclerosis, I think is a very a good thing. The good news about heart disease, at least there are many heart diseases. There are 100 different heart diseases, but the main one is atherosclerosis. And that's called coronary artery disease when atherosclerosis affects the coronary arteries. And this is the coronary artery, which is terribly narrowed. Now, if you just look at that person next to you, one of you is going to die because of arteries that look like this. Now, I know it's the other one, not you, but atherosclerosis will kill about half of us in this room. And the sad fact is that it is preventable. It's clearly hereditary in 1 out of 500 people. There are some who argue, well, it's really 1 out of 200. The point is that when we pull our chair up to that table 21 times a week, we are determining whether our arteries are going to look like this or whether or not they're going to stay wide open. The good news is that it can be prevented, and if you've had a heart attack, this atherosclerotic process can be arrested. Let me try to answer in this presentation 6 questions. Question 1, how much, most of these slides going, oh, I can do it, sorry about that. How much atherosclerosis, and I'm sorry for such a complicated word, but that's the name of the disease, atherosclerosis. Sclerosis means scar. Athero means some cholesterol or lipid material in the plaque. So how much of this stuff is needed in the coronary arteries? Now, the coronary arteries are the arteries which supply the heart muscle with blood to cause myocardial ischemia. Again, a fancy phrase, but that means that myocardial means heart muscle. Ischemia means it's not getting enough oxygen. So how much of that atherosclerotic plaque do we need in these arteries to keep that heart muscle from getting enough blood? Well, acute myocardial infarction is when you have that chest pain and it's prolonged over an hour or so, and you come to the hospital. This slide is an attempt to show how much narrowing is present in people who have heart attacks. Now, these coronary arteries that I've talked about, this is one and this is another one, and it branches into this branch and that branch. If you put all those arteries together, it's about that long. And the question that this slide tries to answer, that if we could divide that length into little bitty segments and ask how many of those segments are narrowed, these various categories of narrowing. Now, 76 to 100% means if you take a circle and divide it into 4 quadrants, how many of those quadrants do you have to obliterate before you have any trouble? Now, the answer to that is about 1/3. And in somebody who has a heart attack, about 1/3 of the lengths of these arteries are narrowed greater than 75% in cross-sectional area. And then another third are narrowed between 51 and 75%. You don't need to remember the numbers. The point is that in order to have a heart attack, we have to have a lot of atherosclerotic plaque. Now, that's both good news and bad news. The good news is that it takes a lot of plaque before we have trouble. The bad news is that despite the fact that it takes a huge quantity of plaque to have trouble, half of us in this room nevertheless go on to develop that huge quantity of plaque. Now, that also means in a way that we don't have to change our habits 180 degrees. If we could change them 90 degrees, that would have an enormous effect on the quantity of plaque we develop in our arteries. Question 2, what do atherosclerotic plaques consist of? If I ask 100 doctors that question, the answer is cholesterol, fat. If I ask 100 non-doctors, the answer is cholesterol, fat. Well, it's interesting that the truth of the matter is that about 75% of the plaque consists of scar tissue. Now, scar tissue is when you cut your arm, it heals by a scar. And the dominant component of these plaques is actually fibrous tissue. Now, there is cholesterol lipid in most of the plaques, but that quantity is approximately 10% in most of them. Now, if we have a heart attack, as mentioned earlier, it means that we've obliterated over 3 of those 4 quadrants before it happens. Question 3, how many direct atherosclerotic risk factors exist? Now, the key word there, of course, is direct, and what I mean by that is how many of these risk factors that we all know about do we have to have before we get in trouble? Now, in my view, we only need one, and that is a total cholesterol level in our blood of greater than 150 milligrams per deciliter. Now, I bet if we went around this room here, there'd be one person, 2 people, probably at most, who have total cholesterol levels less than 150. So what does that mean? That everybody in this room, essentially, is a potential candidate for atherosclerosis. Now, you might laugh, well, it's impossible to reach that. Well, when we're born, our umbilical blood has a total cholesterol of 75. Within 2 weeks of life, it shoots up to about 150, and it stays about 150 until we're 20 years of age. And then after 20, it gradually goes up. The total cholesterol level of pure vegetarians is what? It's about 135 or 140. So we can do it, but there are not many of us that want to go to that, quote, drastic step. Now, that does not mean to say that high blood pressure is not important. Of course it's important. We have 60 million Americans with high blood pressure. If you want to prevent a stroke, keep your blood pressure down. If you want to have a stroke, just let it get out of control. Cigarette smoking, you can't be healthy and smoke cigarettes. It's as simple as that. If you smoke 5 cigarettes a day, your chances of cancer of the lung are 5 times those of people who do not smoke. If you smoke 20 cigarettes a day, your chance of cancer of the lung is 20 times that of people who don't smoke. If you smoke 40 cigarettes, it's the same. And now the reason I came to this 150 here was a number of years ago, I had a trip to Central Africa, and I examined a number of hearts of patients in Central Africa. And high blood pressure in Central Africa is extremely common, and that's what makes the heart so big. And those people were smoking a lot of cigarettes. But I looked at these coronary arteries and no atherosclerotic plaques. Why? Their total cholesterols were 90, 100, 110, 120. So it is possible. It's very difficult in the USA. What factors indicate that cholesterol causes atherosclerosis? This is not a controversial issue, folks. The data is clearly in. If somebody asks me at a reception or party, "Doctor, what causes hardening of the arteries?" I say cholesterol. It's one factor, and the others accelerate it if the total cholesterol is greater than 150. Now, all this started about 1908 when some Russian physiologists fed certain animals, and the animals they chose were rabbits. You can give your dog or cat all the fat, all the cholesterol you want to, and you cannot produce an atherosclerotic plaque. You cannot produce an atherosclerotic plaque in a carnivore. The only animal you can produce an atherosclerotic plaque in is an herbivore. So they gave these rabbits high cholesterol diets. Actually, what they did was they took raw red meat, produced plaques. Then they took fat and produced plaques. And then they took pure egg yolks, which is essentially cholesterol, and produced plaques. The next thing that happened was that these plaques were ground up, and biochemists found cholesterol within them. The third thing that happened was actually after World War II, when some investigators went to various countries and they examined a lot of patients to see who had coronary artery disease and who didn't. And I conclude from those studies this statement: atherosclerotic plaques large enough to produce clinical problems occur only in people having serum total cholesterol levels greater than 150. That 150 is an important number, and that's a goal. Not all of us are going to reach that, but that's what we should try to do. In my view, there's been too much emphasis on decreasing risk. So if you have a cholesterol level of 240, your risk is higher than if your level is 220. If your level is 220, your risk is higher than at 150, or 200, I mean. But if you're at 150, you do not form plaques. And if you have a level of 240 and you bring it down to 150, you don't form any more plaques. Now, the fourth thing is 4, 5, and 6 here were really solidified the last decade. That is, the higher the blood total cholesterol level, the greater the chance of having symptomatic atherosclerotic disease. And atherosclerosis occurs in the coronary arteries. They can occur in the carotid arteries, those in the neck. They can occur in the head. They can occur in the aorta and in the peripheral arteries. So atherosclerosis is atherosclerosis is atherosclerosis, wherever it might be in the body. The greater the chance of dying from atherosclerotic disease, and the greater the extent of the atherosclerotic plaques at the time of autopsy. Now, this item here was solidified in 1984, confirmed in 1987, and magnificently confirmed this year, only 1 month ago, and that is lowering the cholesterol level in the blood decreases the chances of fatal and non-fatal atherosclerotic disease. And this number 6 is very important. And that is, if you take a group of people who've had a heart attack and their cholesterol number is up here and you lower it down to here, you decrease the frequency of a subsequent heart attack enormously. Does everybody in the room know what your cholesterol level is? Everybody? How many know? Do you know all the numbers? Do you know your total cholesterol, the LDL, the HDL, and all of it? Well, let me tell you, the next time you go to your doctor, write them down. The next time the person takes your blood pressure, write it down. Keep it in your wallet. Keep a record of it. Every time I get my cholesterol levels done a couple of times a year. Whenever I can get them done free, I get them done. But I would recommend that. Then you know where you are. Now, the cholesterol problem in the USA is terrible. We have 25% of the population between ages 20 and 75 have total cholesterol levels greater than 240. Now, that's a very high number, folks. Now, the yellow here is men, the red here is women. Men sort of go to pot between 35 and 40, and men have higher levels than women earlier in life, or at least a higher percent of levels over 240 are in men than in women. But after menopause, women catch up very frequently. such that the percent of women with total cholesterols greater than 240 after age 55 is approaching 40%. Now, ladies, you have 1 in 9 chances of dying from cancer of the breast. You've got 1 in 2 chances of dying from atherosclerosis. A major, major problem in women. In 1992, more women than men died from heart attacks. Now, total cholesterol consists of 3 things. It consists of HDL cholesterol. Now, the H means healthy. That's the good cholesterol. Now, the L means lousy. So the LDL is the bad cholesterol. Now, HDL, you want as much of this as you can. And women have a little higher levels of HDL than do men. And most of us, that HDL stays about the same all of our life. Now, the LDL, again, in men, it's higher than in women earlier in life. And in women, it's higher after menopause than men. But that LDL, the reason the total goes up as we get older is not because there's any change in HDL, but it's because the LDL goes up. And the LDL is the bad one. Now, this is Ansel Keys' famous 7-nation study. He and his colleagues went to these 7 countries. This was all done in the 1960s. They studied about 13,000 people and found, they were all men, sorry ladies, and found that the evidence of heart disease was very low in certain countries like Japan and Greece, very high in other countries like USA and Finland. Now, at this time, only 10% of the calories that the Japanese were eating were coming from fat. In other words, in the 1960s, that was a vegetarian society. Finland, on the other hand, 45% of their calories were coming from fat, very high. Now, in the southern Japan, the group that Dr. Keys studied, the average cholesterol was 150. Look at that. So it can be done on planet Earth by human beings. In Finland, it was approaching 300. Now, Ansel Keys in the 1960s concluded this was a cholesterol problem, this atherosclerosis. This is a study I like a lot. It was published in 1986. The reason, look how many people were studied. Over 350,000. Again, ladies, sorry, these were all men. When they entered the study, they were 35 to 57 years of age. They had no evidence of heart disease. They were divided into 10 groups according to their blood total cholesterol level. And what we see here is those numbers go up, 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 and up. The coronary artery disease mortality, and this is only 6 years. It's higher at 10 years. It's higher at 12. It's higher at 16. Goes up, 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 and up. No study shows it better. That total cholesterol is a quantity. The higher the quantity, the greater the risk. Now, it's also not only the quantity, but the length of time that you've had that quantity. Now, if your total cholesterol is 260 for 40 years, that's very different than being 260 for 2 or 3 years. Now, this slide is based on what are called primary prevention studies. And what was done here, a large group of people were studied who had high cholesterol levels, never evidence of heart disease, and these levels were lowered down to here by a drug, and the people on the drug were compared to those not on the drug. And what happened? Turns out that if you look at total cholesterol level, for every 10% that you lower it, let's say your total cholesterol is 200, and you lower it to 180% increase in heart attack frequency. Now, this slide is based on about 14 studies having to do with coronary angiography. Now, these were people who had already had a heart attack. Their cholesterol numbers were up here. They also had coronary angiography shortly thereafter, and the people were followed and a repeat angiogram at 1 year, 2 years, 2.5, or 4 years later. And what this shows is this. If you look at the treatment group, and most of these groups were treated with cholesterol-lowering drugs, there was evidence of regression by coronary angiogram from comparing the subsequent study to the initial study. In other words, if you have a have a heart attack, and your cholesterol level is 260, and you bring that cholesterol level down to 160, these plaques, which may be like big mountains, they get much smaller. And I've seen people who have heart attacks and have a total cholesterol level, let's say, way up here, and the heart attack didn't cause a lot of muscle damage, and they brought their cholesterol levels down here. They were much healthier after the heart attack than they ever were before the heart attack. Sometimes it can work as a stimulating shock. Now, even more important than whether or not atherosclerotic plaques can shrink, this is a very important slide here, and that is, if you have a heart attack and you have a cholesterol level up here and you lower it down to here, your chances of having a subsequent heart attack diminish enormously. In these various studies here, in this STARS study, and these patients were treated with a cholesterol-lowering drug after a heart attack and compared to a control or placebo group, there was nearly a 90% reduction in subsequent heart attacks in the treatment group compared to the non-treatment group. In this study, it was about 80%. In this one, it was about 60%. Everybody knows to take an aspirin tablet after a heart attack. It's better to do it before a heart attack. It decreases a subsequent heart attack about 25%. There's another drug called beta blockers, a class of drugs. They decrease it by about 25%. But cholesterol-lowering drugs have that capacity up to 90%. Now, this is one of the best of the so-called secondary prevention trials. 80% of the people in this trial had a heart attack, an acute myocardial infarction, and 20% had angina. That's the transient chest pain that you get when you walk up a hill. The 4S means the number of people studied were 4,444. The S means that the study took place in the five Scandinavian countries. And this study was continued until 440 patients had died. In the treatment group, these patients were treated with either 20 milligrams or 40 milligrams of a cholesterol-lowering drug made by Merck called Zocor. It's the best of the cholesterol-lowering drugs, in my opinion. And I have no stocks in any pharmaceutical company, so I'm totally free of that situation. But look at what this study showed. And this study went on for 5.4 years. There was a 30% overall reduction in death, a 42% reduction in coronary death, that is a subsequent heart attack, a 34% reduction in any kind of coronary event, a 37% reduction in need for revascularization procedures. Now, what is that? That's these balloon angioplasty or coronary bypass operation. The need for them decreased 37%. And I can tell you that in the 5 Scandinavian countries, they don't do these procedures very often. At my hospital, that'd been a 75% reduction in need for these procedures. So we can diminish the cost of medical care enormously by better use of these drugs. That was a wonderful study. The evidence, in other words, is that if we lower our cholesterol levels either before a heart attack or after a heart attack, we decrease our chances, number one, of developing the first heart attack, and number two, of having a subsequent heart attack if we've already had one. Question 5, how can symptomatic atherosclerosis be prevented? And if present, how can it be arrested? Anybody? What's the answer to that question? Diet. What? Okay, so what's our goal? 150. Whoa, I like you. If our number's 150, our challenge in life, in a way, is to keep it there. If it's higher than that, our challenge is to get it down to that. If it's 150, atherosclerotic plaques do not form. Question 6, how can normal cholesterol levels be prevented from rising, and how can elevated levels be lowered to normal? Now, this is the challenge. It's a challenge for all of us. Well, we've got to do 3 things. We've got to decrease the quantity of cholesterol we take in. We've got to decrease the quantity of fat we take in. And we almost certainly have to decrease the quantity of total calories we take in. Now, this slide has to do with cholesterol. 3 different studies. Each line represents a different group of investigators. And what it shows, as we increase our cholesterol intake, our cholesterol in the blood goes up. Now, that's in groups of people. In single individuals, it's not perfect. Some people can take in 3 eggs and the cholesterol will shoot up. Others of us can take in 3 eggs and it won't change much. So there is considerable individual variability in our response to cholesterol intake. But for most of us, the more we take in, the higher our cholesterol level. Now, as a matter of fact, I don't worry nearly as much about cholesterol as I do fat. Most of us take in about 500 milligrams or 400 milligrams of cholesterol every day. Now, how do you picture that? That's not much. I can tell you that a toothpick weighs 100 milligrams. So most of us take in only 4 or 5 toothpicks of cholesterol every day. And as I'm sure you know, all cholesterol comes from animals and their products. So if we quit eating animals and their products, our cholesterol battle is beat. Now, about almost half of the cholesterol we take in comes from eggs, the visible and non-visible ones we eat. And the biggest other portion, source of cholesterol, are cows. Bovine muscle, we call it beef, milk, cheese, butter, that's most of the rest of it. So if we could give up cows and give up eggs, or at least decrease the quantity in each of those, our cholesterol problem would clearly be beef. Now, fat is another situation. Most Americans take in over 100 grams of fat every day. Now, how do you picture that? I can tell you that a deck of cards weighs 75 grams. None of us should take in more fat than a deck of cards every day. Probably we'd be much better off if we took in no more than 50 or 60 grams of fat every day. I can tell you there's one person on planet Earth who's advocating that we take in no more than 30 grams of fat every day. And if we did, our health would truly skyrocket. There's several sources of fat. The problem with fat is about 1/3 of it is saturated. The other 1/3 is monounsaturated and polyunsaturated. Now, monounsaturated and polyunsaturated either have a neutral effect on our cholesterol levels or they lower them. Saturated fat, on the other hand, shoots them up. Now, how do you remember saturated? The S in saturated stands for solid. So if you see grease in a platter on your stove, and if it cools to room temperature, and if it's solid, that means it's saturated. Don't eat it. Also, these boxes in grocery stores, the word hydrogenated. This is a hydrogenated fatty acid. Now, what does that mean? A fatty acid is a carbon chain covered by hydrogen atoms. And the hydrogenation process means that you take a polyunsaturated fat or a monounsaturated fat and you add hydrogen to it. So what you're doing is converting a monounsaturated or a polyunsaturated fatty acid to a saturated fatty acid. So if you see the word hydrogenated, stay away from it. That means saturated, essentially, and that's bad. Now, if you want to get a quick grease job rapidly, there's no better place than the fast food industry. This is approximately $70 billion industry now, as you know. 50% of money spent for food eaten outside the home in the USA is spent at a fast food chain. 20% of Americans eat their lunch every day at a fast food chain, 13% their supper, and 5% begin their day at a fast food chain. These two people went around to try to determine the ingredients of these hamburgers. At the moment, these keep changing, but Carl's Jr. Double Western Bacon Cheeseburger, folks, that's the coronary artery bypass special. And it's closely followed by Jack in the Box Ultimate Cheeseburger and Burger King Double Beef Whopper with cheese. We're talking about nearly 1,000 calories in those hamburgers. And if you take those suckers and squeeze them real hard, you can come up with about 15 teaspoons. Now, that's not grams, but teaspoons of fat in that single hamburger, and much of that, over half, is saturated. Now, sodium, this is not salt, not sodium chloride, but sodium alone. None of us should take in more than 1,800 milligrams of this every day, and you can get all of it in Carl's Jr. right there. I'll have the half-pound double deluxe bacon steer burger, please. You want chemotherapy with that? This fella, John Love, wrote an interesting book. He called it McDonald's Behind the Arches. Some of you probably heard Bill Castelli talk about this subject. He's head of the Framingham Heart Study in Massachusetts. He calls the arches of McDonald's the entrances into the pearly gates, and I think he's right. Look at this one. Slightly more than 50% of the population of the USA lives within 3 minutes of a McDonald's. This is an old slide, actually. McDonald's has now served over 100 billion hamburgers, and think how many atherosclerotic plaques. McDonald's has employed at one time or another over 8 million workers, 7% of the entire U.S. workforce, and McDonald's has replaced the U.S. Army as America's largest job training organization. McDonald's is the world's largest owner of commercial real estate. That's just one of them. There was another book that appeared a few years ago entitled In One Day. The author asked, what do we consume in the USA every 24 hours? Well, about 815 billion calories of food consumed every day, roughly 200 billion more than we need. Now, those 200 billion left over would feed the whole country of Mexico every day, no problem. In 1960, folks, we reached 60%. 3 out of every 5 adults in the USA age 18 and over are overweight. When I was at NIH, where I was for 32 years, we had a lot of foreign visitors. Whenever they'd come into my office, I would always ask them, what strikes you most about Americans? Number one answer was how many fat people we have in the USA. No nation in the history of planet Earth has seen the problem of overweightness that we have in this nation. Nearly 100,000 cows are slaughtered every day in the USA, yielding 60 million pounds of red meat. As you know, in this country we have about 260 million people, and we have 100 million cows, and we kill about 100,000 of them every day. And we do it differently in the USA and Canada than in the rest of the world. As you know, we bring them into these feedlots that last the 5 or 6 months of their life, and they'll feed them 20, 25 pounds of grain and soybean every day. And why do we do that? We do that, of course, to make them fat, because when they're fat, they taste better. And then we kill them, and then they kill us. And that's the way the system works. Now, we also butcher about 250,000 hogs every day and eat about 4 million pounds of bacon. Bacon is really the pits. It's about 85% fat. It's better to eat I'm convinced, better to eat the egg on the plate than it is bacon. Now, if you don't know what it is, make a hot dog out of it. And we eat about 47 million of them every day in this country. McDonald's puts 2,500 cows on their table every day. Dairy cows yield 47 million gallons of milk every day. We eat 170 million eggs every day. And folks, if you're a chicken, don't wander into the USA. We're up to 19 million chickens killed in the USA every day now. And 60% of them have salmonella in that muscle. So if you're going to eat them, cook them real well done. We also eat about 50 million pounds of sugar, an average of 21 teaspoons apiece. Can you imagine waking up in the morning, looking at your bedside table, and seeing 21 teaspoons of sugar out there? These processed foods we all eat, they're loaded with sugar and they're loaded with salt. We also drink about 16 million gallons of beer and ale and 1.5 million gallons of hard liquor, enough to make 26 million Americans thoroughly drunk every day. We still smoke about 85 million packs of cigarettes. 3,000 to 4,000 teenagers take up smoking every day. I like this statement by Dr. Collins. He says, the carnivore animal has almost an unlimited capacity to handle saturated fats and cholesterol, whereas the vegetarian and herbivorous animals have a very restricted capacity to handle these food components. It is virtually impossible to produce atherosclerosis in the dog, even when 100 grams of cholesterol, now that's 200 times the average daily intake in the USA, plus a quarter of a pound of butterfat are added to its meat ration. In contrast, adding only 2 grams of cholesterol daily to a rabbit's chow for 2 months produces striking fatty changes in its arterial wall. Now, are we more like the rabbit or more like the dog? Can we turn these lights out up here? I think these slides will show up a little better. Well, here's some characteristics of carnivores. Yeah, that's better. Now, when you look down at your appendages, do you see claws or do you see hands we're supposed to be using for gathering those fruits and vegetables? Now, there are those who argue, well, these teeth in the front of our mouth are sharp, but most of our teeth are flat for grinding. Now, the intestinal tract, you give your dog or cat something to eat, they got to go outside in a few minutes. They have a very short intestinal tract. Now, a human being, the small intestine alone stretched from that wall over there to this wall over here. Very long, plenty of time to extract those nutrients from the fruits and vegetables we're supposed to be eating. Now, how do you cool your body? Do you pant like a dog or do you sweat? Now, when you drink water, you know, the cats lap it, we sip it. Vitamin C, the carnivores make their own vitamin C. I don't know any human beings that make their own vitamin C. Folks, I think we're one of these carnivores, and we certainly conduct our lives as if we were, but I would suggest, as have many others, that basically, fundamentally, this is the group we're in. Now, I'm not idealistic enough to believe we're going to walk out of this room and not eat any more flesh, but I'll tell you, if we're going to change the health of this nation, we have got to decrease the quantity of it we all eat every day. And the cows will be very grateful, and so will the chickens and the pigs and all the rest. Now, if we can look at this situation from the standpoint of those who eat no flesh and ask what diseases do they not get? In other words, if we could put the pure vegetarians in this room over against this wall over here, and the meat eaters, which most of us are, against this wall, and ask which diseases these pure vegetarians over here don't get, or very unlikely to get, look at this, atherosclerosis. It's going to kill 1/2 of us in this room. But those vegetarians standing over there, they don't get it. High blood pressure. We have 60 million Americans with blood pressures greater than 140/90. Now, the normal blood pressure in actuality, at birth, it's 90/60. And in societies that eat no salt, at age 20, it's 90/60. At 40, it's 90/60. At 60, it's 90/60. It does not go up with age. So when we're talking about 140/90, we're talking about a number which is 65% higher than it ought to be before we call it high blood pressure. Certain cancers, look at this, ladies. 5%, 4% of breast cancer is genetic. The other 95% is not. Cancer of the colon, very uncommon in pure vegetarians. Look at this, gentlemen, prostate gland cancer. There was a paper appeared not long ago. Heavy meat eaters have a much higher frequency of cancer of the prostate gland than light meat eaters. Diabetes after age 50, just unheard of virtually in pure vegetarians. They're not obese, they're not bothered by peptic ulcer, constipation, hemorrhoids, diverticulosis, appendicitis, irritable bowel syndrome, hiatal hernia. Look at this. No gallstones, no kidney stones, and look at this, ladies. osteoporosis. In this country, it's estimated by age 65 that the average woman has lost 35% of her skeleton. 35%. Why? Because we're not taking enough calcium? Almost surely because we're taking in too much protein. And the more protein we take in, the more the calcium lost in the urine. Osteoarthritis, a major problem in this nation, very uncommon in pure vegetarians. Now this slide comes out of the Harvard School of Public Health. It analyzes 20 studies on the relationship between body weight and what they call mortality ratio, which simply means when we die. And what we see here, whether you're a man in the upper one or a woman in the bottom one, the more we weigh, the sooner we die. Now we can all point out the Winston Churchills on planet Earth, but they're the exceptions, not the rule. Obesity, as mentioned earlier here, is a major problem in this country. Now this is just the percent of the population who are obese. Obesity is defined as 20% or more above desirable weight, meaning if you should weigh 160, you weigh 200. So we're talking about frank obesity. And look at this. Black women in this nation, 45% nearly, are obese. Not overweight, but obese. It's a major challenge for us all. In the white population in this nation, about 25% are obese. 60% overweight. Now this slide has to do with cancer of the breast. Why is he talking about cancer of the breast? Look at this. On the horizontal axis here are the grams of fat consumed by adults in these various countries around the world. Here we are, USA, right there. We are over 140 grams of fat consumed every day. We have one of the highest frequencies of cancer of the breast. But this could also be cancer of the colon. It could also be atherosclerosis, and it could also be high blood pressure. The lower the quantity of fat consumed by any society, the lower the frequency of atherosclerosis, the lower the blood pressure, the lower the frequency of two of the three most common cancers, namely breast and colon. Can we change our health? Of course we can. It took World War II to produce this slide, 1939 to 1945, and as you know, in certain countries during that period of time, there was not much red meat available, not much butter, not much cheese, and not much milk. And what happened to the cardiovascular death rate? Well, in Sweden, boom, it fell. In Finland, boom, it fell. In Norway, boom, it fell. The USA, it just kept on going up. Sure, we can change our health. The most commonly prescribed diet in the USA by physicians is 30% of calories from fat. Most of us are eating about 38 to 40% of our calories from fat. Now, if you lower the percent of calories from fat from 40 to 30, what does it do to the total cholesterol? What does it do to the LDL cholesterol? It lowers those by 5%. Now, in some people, it will lower them by 20%. In other people, when they lower the percent of calories from fat by 25%, the cholesterol levels actually go up. So there's a huge variability among us. But on the average, there's only a 5% reduction. So after I have a heart attack, I'm not going to waste my time in trying to decrease my percent of calories in diet from 40% to 30%. Unless you go down here to 20%, you're not going to gain a great deal. Now, if you can go down to 20%, you lower your total cholesterol by about 20%, which would be from 200 to 160. So if you can get it down here, you're making enormous strides with diet. If you can get it to 10%, you have to be a pure vegetarian fruit eater at that point. But if you get it down to 10%, these cholesterol-lowering drugs would not be necessary. Now, these are a list of cholesterol-lowering drugs we have in the USA. I think that I tend to put some of these cholesterol-lowering drugs in the same category of penicillin, meaning that they have the impact to make an enormous change in the health of this nation. Now, I'm a statin person. These last four drugs here are the so-called statin drugs. And these are the only drugs you can take once a day. And if you take sufficient doses of them, the effects on total cholesterol, the bad cholesterol, LDL, is terrific. HDL goes up and triglyceride levels go down. So these are magical drugs. And in my view, they should be taken far more often than they are. We have in this nation approximately 7.5 million people with symptomatic myocardial ischemia. That is, they've had a heart attack, they have angina pectoris, they have congestive heart failure because of narrowed coronary arteries, they have a bad ventricular rhythm due to coronary artery narrowing. All of these people, 7.5 million, ought to be on a cholesterol-lowering drug. How many do you think are on it? Less than 1 million. Less than 1 million. So in my view, everybody with symptomatic atherosclerosis, be it a narrowed carotid artery, artery in the leg, abdominal aortic aneurysm, all of these patients should be on a cholesterol-lowering drug in my view. They should work in getting the amount of fat and cholesterol eaten in the diet down, but in the meantime, they should be on these drugs. The people with familial hypercholesterolemia, all of them need to be on a drug. Now, we're talking about here 1 out of 500 people, maybe 1 out of 200 people. Diet alone is not going to be adequate. The biggest challenge we have in cardiology today, in my view, is when to put all this group of people on cholesterol-lowering drugs. If I had diabetes, most patients with diabetes die from atherosclerosis. If I had diabetes, I'd be on a cholesterol-lowering drug, and I'd make sure I got that total cholesterol down in the 150 range. If I was a heavy cigarette smoker, had high blood pressure, was obese, and my cholesterol levels weren't quite normal, even though I had no evidence of heart disease, I think I would be on a cholesterol-lowering drug. In other words, if you have a heart attack, you know you've got an artery narrowed greater than 75%. And when you have a heart attack, you damage heart muscle, and that makes it a problem. 25% of people who have a heart attack, their first chest pain is their last chest pain. 25% of the people who present with heart disease present with death. So we're only talking about 75% of the people we can do something about. So in my view, we've got to start cholesterol-lowering treatment in this category before an artery gets over 75% narrowed. This is one way to look at the situation. If you put yourself on this line, it means you're asymptomatic. You've never had a heart attack, no evidence of atherosclerosis. These are cholesterol levels here, and this is the risk of an atherosclerotic event. Let's say you have a total cholesterol of 310. If you knock it down to 270, you decrease your chance of a heart attack in half. If you knock it from 270 to 230, you knock it down in half again. If you knock it from 230 to 190, you knock it down in half again. Now, 190 is average for the USA here, or about 200. So that's not good enough, but that pays big dividends. Now, if you've had a heart attack, you shift that line to the left. So now you go from 270 to 230, you decrease your chance of another heart attack by 50%. If you go from 230 to 190, you decrease it in half again. If you go from 190 to 160, decrease it in half again. Pays big dividends to get those numbers down. Now let me show you one slide on hypertension. I'm almost done here. This is a slide made in 1972. If you had high blood pressure in 1972, 40% of those who had it were unaware that they had high blood pressure. Of the 60 who knew they had it, 30 were not seeing a physician, and of the 30 who were, only 15% were being adequately treated. So in 1972, in this nation, out of 100 people with high blood pressure, only 15 were being adequately treated. Now today, that 15% is up to 50%, and the stroke frequency in this country has dropped 50%. Now, if we substituted here high cholesterol levels for hypertension, what do you think that number would be? And I will tell you, it is far less than 5%. So we've got a long way to go. These are coronary arteries in a woman who was 103 years of age. And these are sites of maximal narrowing. That's the left main coronary artery. It's beautiful. I'll trade with her right now. This is a right coronary artery. That's the biggest plaque in her body, but look how big the lumen is. This is the artery in the front of the heart. Beautiful artery. The reason I show this is simply to point out that we don't have to get atherosclerosis just because we get older. This is not a degenerative disease. We are the degenerates, I'm afraid. This poor woman was run over by an automobile. I like Mark Twain's statement. It says, the only way to keep healthy is to eat what you don't want, drink what you don't like, and do what you'd rather not. So, folks, it's up to you and it's up to me. Thank you very much.
So much, Phil. If anybody has any questions, we'll be more than glad to. Somebody has a question. Yes.
After you go on this regimen, does the scar tissue that you referred to disappear?
Well, that's a good question. As mentioned, these atherosclerotic plaques consist mainly of fibrous tissue. Fibrous tissue is of two types. One is a cellular vanish from the plaques as the cholesterol levels are lowered. The point there is let's say if 10% of the plaque consisted of cholesterol. If you got that out of the plaque, the amount of lumen that would open up would probably be greater than that. In other words, small changes in plaque mass can lead to very significant changes in lumen size. You only have to get that lumen size to less than 75% narrowed. And if you get it to less than 75% narrowed, every engineer I've talked to about this says that flow through that artery should be normal. Yes, sir.
On the cholesterol-lowering drugs, different levels of drugs have
Absolutely, that's a good question. Now, there are 4 statin drugs. Now, essentially, all of the statin drugs work the same way. But they have different power, different effectiveness. For example, 10 milligrams of Zocor is equivalent to 40 milligrams of Lescol. Now, with Zocor, you can go up 10, 20 to 40. With Lescol, you have to start at 40, and then the next one is 80, and the next one is 160. Well, they have no approval at the level of 80 milligrams or 160 milligrams. Merck, interestingly, with their product, they have 2 of the 4. With one of their products, they essentially have the same price at 20 milligrams and at 40 milligrams. So that's one of the major reasons that I advocate their drug. It's the most powerful one. It's approved by the FDA at the higher doses. And there's essentially no difference in price at the 20 milligram tablet and the 40 milligram tablet. And a year ago, I was preaching for the lowest doses. Today, I'm pushing the higher doses because it's only with the higher doses that you're going to get your total cholesterol down to the 150 area or the LDL down to less than 100. I would recommend going to the 40, depending on what your numbers are, and you get a little more benefit at the same price. Now, the toxicity of these drugs is extremely minimal, and compared to the toxicity of atherosclerosis, they're virtually non-toxic. In the 4S study, there were 2,221 patients treated with Zocor for 5.4 years. One person had a side event, adverse drug effect, with muscle weakness. They were taken off the drug and the strength of the muscle came back immediately. So the toxicity is it's almost a problem, not a problem at all. Zocor. That's their name. The generic name is Simvastatin. They all have the same side effects, and but all of them are minimal. I mean, if you compared to the side effects of elevated cholesterol levels, these things are magical. And you take them only once a day. They're little bitty pills.
You have the cholesterol of the average American at 190.
No, actually the average level is about 210.
Whatever, let's say 200. Does it make any difference at that level what the ratio of the good and the bad cholesterol are?
Yes, sir, it does.
What ratio do you?
Let me come back. Let me make the point that, in my view, if you've had an atherosclerotic event, the first thing to go on is a drug. And I advocate drug in very high doses. Now, if you have no evidence, and then work on the diet as you can. In people who have high cholesterol levels at age 30, 35, younger, I would push diet till you just have to give up on it, and then start them on a drug. But in somebody with no evidence of heart disease, unless they're a diabetic, I would go slow with the drugs. But in people who've had a problem, I'd go with the drugs immediately. Your question about what about the ratio between the bad cholesterol and the good cholesterol, that is the LDL and the HDL, or the total in the HDL. The HDL is the good one. You want that to be as high as it can. Women, as you've seen, have higher levels in general than do men. Well, I think it's more important to know what's low. If it's under 35, that's not good. Now, one problem is if you can bring the total down to 150, sometimes the HDL gets under that. But I don't worry about the HDL if the total is about 150. It's very hard. The other problem there, it's very hard to raise the HDL with drugs. These statin drugs will raise it about 8%. There's another drug that has the reputation of doing that, but it's really not very effective. The best thing to raise HDL is to lose weight if you're overweight, to exercise, and to drink a little wine. Now, I wouldn't advocate anybody drinking alcohol unless they do, but if you do, it's very useful in helping it go up a little bit.
About 20 years ago, I had picked up high cholesterol and high triglycerides. Just put on a diet. The diet was low carbohydrates, very high protein. Fried chicken, steak, and all this. Strangely enough, my cholesterol went down under 140. Triglycerides went down 170, something like from 800. I went back about a couple of months ago. I had elevated cholesterol and went to a different physician. Mentioned that diet to him in his lab. And he said, no, if you want to put you on a cholesterol-reducing drug, you need to go to fat diet. How would you help with that?
Well, I'll tell you my view. I'll tell you my view about nutrition and physicians. When I went to medical school, we didn't have 1 hour of lecture in 4 years on nutrition. When I graduated from medical school, I didn't know the caloric count of a single food. I didn't have any idea what a saturated fat and a monounsaturated and a polyunsaturated fat and all that stuff was. I mean, I learned from women something about food. And then I started buying those calorie books, so every time I'd go through a cafeteria line, I could check it out, and, you know, like bridge hands, and finally I started learning something about it. So if I was going to a physician, and this physician recommended to me that I be on certain diet, and I saw that that individual was about 20 pounds overweight, I'd ask him or her what kind of food they ate. What do you know about nutrition, sir or ma'am? And not a lot of doctors know a lot about it. There are some who do. But if you take 100 people and advocate meat and fried chicken and so on, you're not going to have the result that you had.
But they recommended protein versus carbohydrates.
Well, I would focus on fat and learn how many grams of fat you're eating every day.
This 20 years later,
Yeah. The villain is fat. And just, I mean, if you have to have an egg, have it on Sunday morning, once a week. You know, make it a treat. Make it a treat. I have an egg sometimes on Sunday morning, but I don't do it every day. I have a dessert like last night, but I don't do it every day. Make it a treat. I tell you what I do, and I've got a bad hip. I used to run, so I don't run a lot in it. I don't run at all anymore. But my rules are this, is that I have a bowl of cereal or a banana for breakfast. And if I have a bowl of cereal, I use skim milk. I don't eat between meals. I think that's awful to eat between meals. When you don't eat between meals, you eat yourself. And when you eat between meals, it's usually junk. So I try not to eat I don't eat between meals. I eat a relatively light breakfast. I try to eat 3 vegetables for lunch or 2. And then I have a pretty good dinner. And the only flesh I eat is fish. And I don't eat before I go to bed at night. But I think we all have to establish a weight. And what is the weight we're not going to go over? Now, my scales in my house are next to the refrigerator. And if I go over my number, I just don't open the refrigerator door. But, you know, a weight is a number. And if I meet somebody, they don't tell me their weight, you know, it's a problem. You got to know your weight, and you got to know which number you can live with. That's my simple rule. But I don't eat. I was a vegetarian, pure vegetarian for 18 months. It's very hard. I eat out a lot. Very hard. You get the same amount of cholesterol in every one of these fleshes we eat. But fish has very little fat in it, and they have some favorable oils in it too. And it's not quite as bad for our environment as cows and pigs and chickens. It's a major problem. I'll tell you my prediction, 20 years from now, when we go over to somebody's house to eat dinner, and they serve you a 10-ounce steak, it's going to be like blowing smoke in your face. We're not going to do it. It's tearing up our environment. And there's going to be a big campaign on it. I can see it. I'll tell you, if you want to learn something about your health, read John Robbins' book, A Diet for a New America. And how do you remember John Robbins? Well, he's the son of the Robbins of Baskin-Robbins fame. So you can see there's been a little problem there. Or read A Diet for, what is the name of it? A Diet for a Small Planet. Written in 1972 by Mary Moore LePay. It was revised 1982. She made a great contribution. She asked, why are there so many starving people on planet Earth? Simple question. What did she find out? She found out that all this grain we were producing was going to the cattle. When we sell grain to Russia, it's not going to people, it's going to the cows. And so we were consuming so much of our land and so on to feed the cattle. And then we'd eat them. But it's a very inefficient process. It's a major, major problem. Yes, ma'am. Well, I think clinicians in general have not been advocates of the cholesterol, have not been believers in the cholesterol thesis. It means that physicians have to change their own habits also to be an advocate of this. And it's hard to change habits. You know, all this fat is delicious. You want to make something taste good, just put some fat in it. It's very difficult. But that's changing. This 4S study has had a major impact. I mean, it's a beautiful study. We just had another study with a statin drug, a pravastatin, showing primary prevention. It works excellent. It's now a case in the courts. Somebody with a high cholesterol wasn't treated. That's going to have a major impact.
Well, we just don't have to give up Tabasco. We'll be all right.
Thank you very much so much.